SEC110NS calcifications. Calcifications can be an early sign of breast cancer. The earliest sign, actually, according to some. Calcifications basically come in 3 flavors: 1. Artifact, 2. Benign, and 3. Suspension 1C1S. Artifact. Deodorant, high-density material seen in the axilla, is the typical appearance. Another trick is to show a speck of high-density material that doesn't change position on different views, inferring that it's on the image receptor. Deodorant artifact. Zinc oxide. This is in an ointment old ladies like to put on their floppy sweaty breasts. Breasts. It can collect on moles and mimic calcifications. If it disappears on the follow-up, it was probably this, or another dermal artifact. Breasts. It can collect on moles and mimic calcifications. If it disappears on the follow-up, it was probably this, or another dermal artifact. Metallic artifact. It's possible for the electrocautery device to leave small metallic fragments in the breast. These will be very dense. Metal is denser than calcium. It will also be adjacent to a scar. 361. Benign vs suspicious. The distinction between benign and suspicious is made based on morphology and distribution, those BI-RADS descriptors. Since most breast cancers start in the ducts, a single duct in most cases, a linear or segmental distribution is the most concerning. The opposite of this would be bilateral scattered calcifications. Segmental linear grouped / clustered regional scattered. Benign, dermal calcification. 361. 300. Benign vs suspicious. The distinction between benign and suspicious is made based on morphology and distribution, those BI-RADS descriptors. Since most breast cancers start in the ducts, a single duct in most cases, a linear or segmental distribution is the most concerning. The opposite of this would be bilateral scattered calcifications. Segmental linear grouped / clustered regional scattered. Benign, dermal calcifications. These are found anywhere women sweat, folds, cleavage, axilla. Just think folds. They are often grouped like the paw of a bear or the foot of a baby. The trick here is that these stay in the same place on CC and MLO view. This is the so-called tattoo sign. If you are asked to confirm these are dermal calcs, I'd ask for a tangential view. MLO I derma calcifications I tangential J. 362. Vascular calcifications. These are parallel linear calcifications. It's usually obvious but not always. __ popcorn calcifications. This is an immediate buzzword for degenerating fibroadenoma. The typical look is they begin around the periphery and slowly coalesce over subsequent images. Secretory, rod-like calcifications. These are big, easily seen, and point toward the nipple. They are typically bilateral. The buzzword is cigar-shaped with a lucent center. Another buzzword is dashes but no dots. The buzz age is 10 to 20 years after menopause. Don't be an idiot and call these in a premenopausal patient. They happen because the duct has involuted. Secretory calcifications. Eggshell calcifications, fat necrosis I call them. It can be from any kind of trauma, surgical, or accident playground related. If they are really massive, you may see the word liponecrosis macrocystica. As I've mentioned many times in this book, anything that sound Latin or French is high yield for multiple choice. Lucent-centered is a buzzword. Dystrophic calcifications. These are also seen after radiation, trauma, or surgery. These are usually big. The buzzword is irregular in shape. They can also have a lucent center. Milk of calcium. This has a very characteristic look, and because of that questions can only be asked in one of two ways. 1. What is it? Shown as cc then ml. 2. What is it due to? 1. On the cc view the calcifications look powdery and spread out, on the MLO view they may layer. I suspect they will show you a ML view because they should layer into a more linear appearance, with a curved bottom T-cupped. For the purpose of gamesmanship if they show you a ML view on a calc's milk of calcium, T-cups on ML question, look hard for anything that resembles T-cupping. 2. It's fluid in a lobule, due to fibrocystic change. 3. No calcifications on the biopsy. Biopsy. This is a common trick. Apparently milk of calcium needs to be viewed with polarized light to assess birefringence. Otherwise you can't see it. I imagine there are several ways to get that via multiple choice. Round. The idea is that these things develop in lobules, are usually scattered, bilateral, and benign. When benign, which is most of the time, they are going to be due to fibrocystic change, most of the time. The best way I've heard to think about these is the same as a mass. When masses are bilateral, multiple, and similar they are considered benign, BR2. When a mass is by itself or different it's considered suspicious. Round calcifications are the same way. They are usually bilateral and symmetric and benign. If they are clustered together by themselves, or new they may need worked up just like a mass. Remember that if grouped round calcs are on the first mammogram you can BR3 them. Suspicious. Amorphous, these things look like powdered sugar, and you should not be able to count each individual calcification. Distribution is key with amorphous calcs, like many other types before. If the calcs are scattered and bilateral they are probably benign, if they are segmental they are probably concerning. Dash. Dash dash. Dash. DDX amorphous Ca plus 2. Fibrocystic change, most likely, sclerosing adenosis columnar cell change DCIS, low grade, dash or dash. Dash. Dash dash. Dash dash. Dash dash. Dash coarse heterogeneous, these calcifications are countable but their tips are dull. If you picked one up it would not be POCU. They are usually bigger than O.SMM. Distribution and comparison to priors is always important. They can be associated with a mass, fibroadenoma, or papilloma. FOOC, A. C. I.O. Fine pleomorphic, these calcifications are countable, and their tips appear sharp. If you picked one up it would poke you. They are usually smaller than O.SMM. L. Fibroadenoma. Papilloma fibrocystic change, DCIS, low intermediate grade. Dash. 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 Dash dash. Dash. LDDX fine pleomorphic Ca plus 2I. Fibrocnoma, less likely, papilloma, less likely, fibrocystic change DCIS, high grade, underscore. Dash dash. Fine linear I fine linear branching, this is a distribution that makes fine pleomorphic calcifications even more suspicious. The DDX narrows to basically DCIS, or an atypical look for secretory calcs or vascular calcs. 364. L. Calcifications associated with focal asymmetry/mass. When you see increased tissue density around suspicious calcifications the chance of an actual cancer goes up. This is sometimes called a puff of smoke sign, or a warning shot. This is a situation where ultrasound is useful, for extent of disease. Gamesmanship, next step. Ultrasound is not typically used to evaluate a pure calcification findings. Exceptions would be A. If the patient had a mass associated with the calcifications, Or B, if the patient had a palpable finding, then they would get additional evaluation with ultrasound. Gamesmanship, highest suspicion for malignancy. Depending on what you read and who you ask, fine linear branching and fine pleomorphic calcifications have the highest suspicion for malignancy. Malignancy. So which one is it? For sure, fine linear branching is the worst. Morphologically, it mimics the ductal proliferation of suspicious calcifications, DCIS. The confusion is that some people use fine pleomorphic as an umbrella term under which linear and branching forms exist. So how to handle this on multiple choice? Choice. If the answer choices include fine linear branching, then that is the correct answer. If the answer choices do not include fine linear branching, but instead have you pick fine pleomorphic vs coarse heterogeneous, or some other obviously benign calx, eggshell, etc., then for sure pick fine pleomorphic. 365. SECT1 SECT10N6 benign path. Mondor disease. This is a thrombosed vein that presents as a tender palpable cord. It looks exactly like you'd expect it to with ultrasound. You don't anticoagulate for it, it's not a DVT. Treatment is just NSAIDs and warm compresses. Fat-containing lesions. There are 5 classic fat-containing lesions, all of which are benign. The oil cysti fat necrosis, hamartoma, galactocele, lymph nodes, and lipoma. Of these 5, only oil cyst/fat necrosis and lipoma are considered pure fat containing masses. Hamartoma, the buzzword is breast within a breast. They have an mini appearance on mammography, although they are difficult to see on ultrasound, they blend into the background. Galactocele, seen in young lactating women. This is typically seen on cessation of lactation. The location is typically subareolar. The appearance is variable but can have an mini look with a fat fluid level. It's possible to breast abscess these things up. Hamartoma, breast within a breast. Oil cysti fat necrosis, these are areas of fat necrosis walled off by fibrous tissue. You see this, 1, randomly, 2, post-trauma, 3, post-surgery. The peripheral calcification pattern is typically egg shells. If you see a ton of them, you might think about steatocystoma multiplex, some zebra with hamartomas. Lipoma, these are typically radiolucent with no calcifications. Enlargement of a lipoma is criteria for a biopsy. Intramammary lymph node, these are normal and typically located in the tissue along the pectoral muscle, often close to blood vessels. They are not seen in the fibroglandular tissue. Practice point ultrasound, LITS palpable. Usually a palpable finding is going to get an ultrasound. If you are under 30, most people will skip the mammo and go straight to ultrasound. One of the exceptions is a fat-containing lesion, definite benign BR, 2CR on diagnostic mammography. 366. L. Pseudoangiomatous stromal hyperplasia. PASH-THE is a benign myofibroblastic hyperplastic process, hopefully that clears things up. It's usually big, 4 to 6 centimeters, solid, oval-shaped, with well-defined borders. Age range is wide and they can be seen between 18 to 50 years old. Follow-up in 12 months, annual, is the typical recommendation. Pseudoangiomatous stromal hyperplasia equals benign thing with a scary-sounding name. Name: fibroadenoma. Fibroadenoma, this is the most common palpable mass in young women. The typical appearance is an oval, circumscribed mass with homogeneous hypoechoic echotexture and a central hyperechoic band. If it's shown in an older patient, it's more likely to have coarse popcorn calcifications, which is a buzzword. On MRI, it's T2 bright with a type 1 enhancement, progressive enhancement. Fill loads, although I clumped this in benign disease, this thing has a malignant degeneration risk of about 0%. They can metastasize, usually hematogenous to the lungs and bone. This is a fast-growing breast mass. They need wide margins on resection, as they are associated with a higher recurrence rate if the margin is 2 centimeters. It occurs in an older age group than the fibroadenoma, 40s to 50s. Biopsy of the sentinel node is not needed, because METs via the lymphatics are so incredibly rare. If it does MET, it's hematogenous. Distinguishing features of fill loads: tumor rapid growth. Hematogenous METs middle age to older women mimics a fibroadenoma. 367 Signon 1 cancer. IDC, invasive ductal carcinoma, is by far the most common invasive breast cancer, making up about 80 to 85% of the cases. This cancer is ductal in origin, but unlike DCIS, is not confined to the duct. Instead, it invades through the duct, and if not found by the heroic actions of mammographers, it will progress to distal mets and certain death. Clinically, the most common story is a hard, non-mobile, painless mass. On imaging, the most common look is an irregular, high-density mass, with indistinct or spiculated margins, associated pleomorphic calcifications, and an antiparallel shadowing mass with an echogenic halo on ultrasound. Invasive ductal NOS, by far the most common type of breast cancer, is the one that is undifferentiated and has no distinguishing histological features. Not otherwise specified, or NOS they call it. These guys make up about 65% of invasive breast cancer. JDC subtypes. IDC types, other than NOS. Tubular, small, spiculated, slow, often conspicuous on growing mass, with a ultrasound. Associated favorable prognosis. With a radial scar. Contralateral breast will have cancer L0, L5% of the time. Mucinous, round, or lobulated, and uncommon. Better circumscribed mass outcomes than IDC NOS. Medullary round or oval axillary nodes can be circumscribed MA-S, without large even in the absence CA laifications. Of METs. Typically younger patient, 40s to 50s. Better outcome than IDC NOS -25%, have BRCA-L mutation. Papillary complex, cystic and solid. Axillary nodes are not common. Typically seen in elderly people, favors people who are not white, and is the second most common, behind IDC NOS. 368. L. Multicentric breast cancer, II multifocal breast cancer. A multiple primaries in the same quadrant, multiple, primaries in different quadrants, classically same duct system, I. Less than 4 to 5 centimeters apart. From one another. T. Hink of this like, multicenter, clinical trial, multiple discrete unrelated sites. Synchronous bilateral breast cancer, this is seen in 2 to 3% of women on mammography, with another 3 to 6% found with MRI. The risk of bilateral disease is increased in infiltrating lobular types and multicentric disease. DCIS, this is the earliest form of breast cancer. In this situation, the cancer is confined to the duct. Histologists grade it as low, intermediate, or high. Histologists also use the terms comedo and non-comedo to subdivide the disease. If anyone would ask, the comedo type is more aggressive than the non-comedo types. Testable trivia: 10% of DCIS on imaging may have an invasive component at the time biopsy is done. 25% of DCIS on core biopsy may have an invasive component on surgical excision. 8% of DCIS will present as a mass without calcifications. Most common ultrasound appearance equals microlobulated mildly hypoechoic mass with ductal extension and normal acoustic transmission. If a test writer wants you to come down on this, they will show it in I of three classic ways. 1. Suspicious calcifications, fine linear branching or fine pleomorphic, as discussed above. 2. Non-mass-like enhancement on MRI. Or 3. Multiple intraductal masses on galactography. Lobular/LC. This is the second most common type of breast cancer, TDCNOS being the most common. It makes up about 5 to 10% of the breast CA cases. This pathophysiology lends itself well to multiple choice questions. Cell decides to be cancer, cells lose adherin, cells no longer stick to one another and begin to infiltrate the breast, like the web of a spider. This infiltrative pattern does not cause a desmoplastic reaction, so it gets missed on multiple mammograms. Finally, someone notices some architectural distortion without a central mass, on the CC view only. You get fancy and call it a dark star. On ultrasound, the typical look is an ill-defined area of shadowing without a mass. ILC, shadowing without discrete mass. 369. Shrinking breast. This is a buzzword for ILC. The breast isn't actually smaller, it just doesn't compress as much. So when you compare it to a normal breast, it appears to be getting smaller. On physical exam, this breast may actually look the same size as the other one. Dark star. Dark star, distortion without a central mass. Architectural distortion without a central mass. The DDX includes lobular carcinoma, radial scar, surgical scar. NIDCNOS. LCVS-JDC, ILC is more often multifocal. ILC less often mets to the axilla. Instead, it likes to go to strange places like peritoneal surfaces. ILC more often has positive margins, and more often treated with mastectomy, although the prognosis is similar to IDC. 370. L. Things to know about LC. It presents later than IDC, tends to occur in an older population. It often is only seen on one view, the CC. As it compresses better, calcifications are less common than with ductal cancers. Mammo buzzword equals dark star. Mammo buzzword equals shrinking breast. Ultrasound buzzword equals shadowing without mass on MRI. Washout is less common than with IDC. Axillary mets are less common. Prognosis of IDC and ILC is similar, unless it's a pleomorphic, LC, which is very aggressive, more often. Multifocal and bilateral, compared to IDC, up to 1/3 are bilateral. Inflammatory breast cancer, the prognosis is usually terrible. They will try and do chemotherapy prior to surgery because the chance of a positive margin is so high. The mastectomy is done for local control, which just sounds awful. A swollen red breast is what you are going to see, and as I'll discuss below under the symptomatic breast section, your differential is mastitis vs this. Skin thickening is a mammography buzzword, non-specific. The inflammation associated with inflammatory breast cancer can actually improve with antibiotics but does not resolve. So don't be fooled in the real world or on a multiple choice test. A dermal biopsy is sometimes needed if you can't find an underlying mass. Paget's disease of the breast is a high-yield topic. It is basically a carcinoma in situ of the nipple epidermis. About 50% of the time the patient will have a palpable finding associated with the skin changes. Things to know about breast pagels. associated with high-grade DCIS wedge biopsy, should be done on any skin lesion that affect the nipple-areolar complex that doesn't resolve with topical therapy. Paget's is not considered T4. The skin involvement does not up the stage in this setting. 371. High-risk lesions. There are 5 classic high-risk lesions that must come out after a biopsy: radial scar, atypical ductal hyperplasia, atypical lobular hyperplasia, LCIS, and papilloma. Radial scar. This is not actually a scar, but does look like one on histology. Instead, you have a bunch of dense fibrosis around the ducts, giving the appearance of architectural distortion, dark scar. Things to know: this is high risk and has to come out at associated with DCIS and / or JDC, I 0%, 30% it's associated with tubular carcinoma *. Atypical ductal hyperplasia, ADH. This is basically DCLS, but lacks the quantitative definition by histology, 2 ducts involved. It comes out A, because it's high risk, and B, because DCIS burden is often underestimated when this is present. In other words, about 30% of the time the surgical path will get upgraded to DCIS. Lobular carcinoma in situ, LCIS. This is classically occult on mammogram. An incidental finding is sometimes a buzzword. The best way to think about LCIS is that it can be a precursor to ILC, but isn't obligated to be. The risk of conversion to an invasive cancer is less when comparing DCIS to IDC. Just like pleomorphic ILC is worse than regular ILC, a pleomorphic LCIS is MO badder than regular LCIS. Atypical lobular hyperplasia, ALH. This is very similar to LCIS, but histologists separate the two based on if the lobule is distended or not. No with ALH, yes with LCIS. It's considered milder than LCIS. Risk of subsequent breast CA is 4-6x higher with ALH, and 1lx higher with LCIS. For the core, the answer is excision. In the real world, some people do not cut these out, and it's controversial. Papilloma. A few most commons come to mind with this one. Most common intraductal mass lesion. Most common cause of blood discharge. You typically see these in women in their late reproductive years, early menopausal years, average around 50. The classic location is the subareolar region, LCM from the nipple in 90% of cases. Mammogram, often normal, occasionally just showing calcifications. US, well-defined smooth-walled hypoechoic mass. Maybe cystic with solid components. Also, tends to have associated duct dilation. Galactography, solitary filling defect with dilated duct. Multiple papillomas, these tend to be more peripheral. On mammography it's gonna be a mass, ES, or cluster of calcifications without a mass. Papilloma, solitary filling defect with dilated duct. 372. PHY Hodes, yes. I mentioned this already under benign disease. I just wanted to bring it up again to make sure you remember that this thing has a malignant degeneration risk of about 10%, some texts say up to 25%. This is a fast-growing breast mass. It occurs in an older age group than the fibroadenoma, 40s to 50s. Multiple masses, sounds bad but actually BR2. To call multiple masses you need to have multiple, at least 3, bilateral well-circumscribed masses without suspicious features. This gives you a BR2. One common trick is to show multiple unilateral masses. That doesn't fly, they have to be bilateral. 373. SECR10NS, symptomatic. Breast pain, this is super common and typically cyclic, worse during the luteal phase of the menstrual cycle. Pain in both breasts that is cyclical does not need evaluation. Instead it needs a family medicine referral for some therapeutic communication. Focal non-cyclic breast pain may warrant an evaluation. Trivia, the negative predictive value of combined mammogram and US for focal pain is right around 100%. When breast cancer is found it's usually elsewhere in the breast, asymptomatic. Symptoms that are actually worrisome for cancer include skin dimpling, focal skin thickening, and nipple retraction. Non-focal skin thickening, breast edema. This is usually the result of benign conditions, congestive heart failure, renal failure. For multiple choice tests, it will always be bilateral. In the real world, you can sleep on one side and have asymmetric edema. As long as the breast isn't red, you can feel confident that it will be benign. On mammography, you will see trabecular thickening, diffuse, and favoring the dependent portions of the breast. Breast inflammation, the swollen red breast. This finding has a differential of two things. 1. Mastitis I abscess. 2. Inflammatory breast cancer. Mastitis I abscess. This is a swollen red breast which is painful. Inflammatory breast CA is often painless. Patients are usually sick as a dog. Obviously, it's associated with breastfeed G and is more common in smokers and diabetics. Abscess can develop, usually staph A. Inflammatory breast cancer. As discussed above, this has a terrible prognosis. The general rule is that a breast that doesn't respond to antibiotics gets a skin biopsy to exclude this. The typical age is 40s to 50s. You are going to have an enlarged, red breast with a peau d'orange appearance. The breast is often not painful, despite its appearance. Mammogram might show a mass or masses, but the big finding is diffuse skin and trabecular thickening. The treatment is fair game for multiple choice because it is different than normal breast cancer. Instead of going to surgery first, inflammatory breast cancer gets cooled down with chemo and or radiation, then surgery. 374. L. Discharge. Women present with nipple discharge all the time. It's usually benign, 90%. The highest yield information on the subject is that spontaneous, bloody, discharge from a single duct is your most suspicious feature combo. Serous discharge is also suspicious. The risk of discharge being cancer is directly related to age, very uncommon under 40, and more common over 60. Asterisk discharge is bad when it's spontaneous, bloody, and from a single duct. Milky discharge. Milky discharge is not suspicious for breast cancer, but can be secondary to thyroid issues or pituitary adenoma, prolactinoma. Any medication that messes with dopamine can stimulate prolactin production, antidepressants, neuroleptics, Reglan. Causes of discharge, not milky. Benign causes I premenopausal woman equals fibrocystic change. Postmenopausal women equals ductal ectasia. L. Worrisome causes. Intraductal papilloma, 904/0, single intraductal mass near nipple FDCIS, 10%, think about multiple intraductal masses. Ductal ectasia, the most common benign cause of nipple discharge in a postmenopausal woman. On galactography you will see dilated ducts near the subareolar region, with progressive attenuation more posterior. Galactography. You take a 27 or 30 gauge blunt tip needle, and attempt to cannulate the duct which is leaking. To determine which duct you want, you'll need to have the patient squeeze the breast to demonstrate where it's coming from. If you manage to cannulate the duct, gently inject 0.2 to 0.3 centimeters cubed contrast, rare to need more than 1 centimeter cubed. You then do mammograms, magnification CC and ML. Filling defect, S, get wire localization. Contraindications, active infection, mastitis, inability to express discharge at the time of galactogram, contrast allergy, or prior surgery to the nipple areola complex. 375. Section 9. Architectural distortion. AD, we are talking about distortion of the normal architecture without a visible mass. This manifests in a few ways, including focal retraction, distortion of the edge of the parenchyma, or radiation of the normal thin lines into a focal point. Architectural distortion vs summation artifact. This is the primary differential consideration, with summation of normal vessels, ducts, and ligaments being much more common. The difference is summation should not radiate to a central point, AD will. AD, all lines radiate to a point summation, lines continue past each other. Surgical scar vs something bad, scars should progressively get lighter and harder to see. Some people say that in 5 to 10 years a benign surgical scar is often difficult to see. Lumpectomy scars tend to stick around longer than a benign biopsy. Basically, look at the priors. If it is a surgical scar, it better be getting less dense. If it's increasing, you gotta stick a needle in it. Workup of AD. If you see it on a screener, you will want to BR0 it and bring it back for spot compression views. If it persists, just know you are either going to BR4 or BR5 it, unless you know it's a surgical scar. You should still ultrasound it for further characterization, may help you decide between a 4 and a 5. 376. Ultrasound trivia. The use of harmonic tissue imaging can make it easier to see some lesions. Be aware that compound imaging can make you lose your posterior features, especially when they are soft to start with, like the shadowing of an ILC. Remember, even if you see nothing, this gets a biopsy. Harmonics can also make not so simple cysts look simple. Things to know for AD. Radiating lines to a single point equals AD plus calcifications equals IDC plus DCIS AD, without calcifications equals ILC even with no ultrasound or MRI correlate, AD gets a biopsy. Never ever BR3 an area of AD. Even if it has been there a while, it still needs worked up. Remember ILC can grow slow. Surgical scars should get less dense with time, not more dense. 377. Section 10, lymph nodes. You found a breast cancer, now what? Before you make the patient cry, it's time to stage the disease. Ultrasound her armpit. About 1 in 3 times you are going to find abnormal nodes. Unilateral vs bilateral, this can help you if you are thinking this could be systemic. Unilateral adenopathy should make you worry about a cancer, especially if they have a cancer on that side. Should I biopsy it? Some people will recommend biopsy if you have the following abnormal features. Cortical thickness greater than 2.3 millimeters, some people say 3 millimeters, loss of central fatty hilum, most specific sign, irregular outer margins. Staging trivia, level 1 and level 2 nodes are treated the same. Rotor nodes are treated as level 2. Level 3 and supraclavicular nodes are treated the same. Special sneaky situations. Gold therapy, back in the Stone Ages they treated rheumatoid arthritis with chrysotherapy. What they can do is show you an Ant Mini type picture with very dense calcifications within the node. Snowstorm nodes, another Ant Mini look is the silicone infiltration of a node from either silicone leaking or rupture. 378. SEC110N11, male breast. There is no more humiliating way to die for a man than breast cancer. The good news is male breast cancer is uncommon. The bad news is that when it occurs it is often advanced and invasive at the time of diagnosis. The male breast does not have the elongated and branching ducts, or proliferated lobules that women have. This is key because men do not get lobule-associated pathology, lobular carcinoma, fibroadenoma, or cysts. Gynecomastia, this is a non-neoplastic enlargement of the epithelial and stromal elements in a man's breast. It occurs physiologically in adolescence, affecting about 50% of adolescent boys and men over 65. If you aren't 13 or 65 it's considered embarrassing, and you should hit the gym. If you are between 13 to 65 it's considered pathology and associated with a variety of conditions, spironolactone, psych meds, marijuana, alcoholic cirrhosis, testicular cancer. There are 3 patterns, nodular is the most common. Just think flame-shaped behind nipple, bilateral but asymmetric, and can be painful. Things that make you worry that it's not gynecomastia include not being behind the nipple, eccentric location, and calcification. Patterns of gynecomastia, ovular. Eye flame shape centered behind eye. Most common. The nipple radiating posterior as it ILJ blends into the fat. Breast is often II tender. Usually lasts less than 1 II a year. IL dot dash dash T dash a dash 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 I dendritic resembles a branching tree. This I. B. L is a chronic fibrotic pattern. J I usually not tender. Underscore 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 IJ underscore. Diffuse. Pseudogynecomastia, bitch tits. This is an increase in the fat tissue of the breast, not glandular tissue. There will not be a discrete palpable finding, and the mound of tissue will not be concentric to the nipple. Lipoma, after gynecomastia, lipoma, is the second most common palpable mass in a man. Male breast cancer, it's uncommon in men, and very uncommon in younger men, average age is around 70. About 1 in 4 males with breast cancer have a BRCA mutation, BRCA2 is the more common. Other risk factors include Klinefelter syndrome, cirrhosis, and chronic alcoholism. The classic description is eccentric but near the nipple. It's almost always an IDCNOS type. DCIS can occur but is very rare in isolation. On mammography it looks like a breast cancer. If it was a woman's mammogram you BR5 it. On ultrasound it's the same thing, it looks like a BR5. Having said that, nodular gynecomastia can look suspicious on ultrasound. Things that make you think it's breast cancer: eccentric to nipple unilateral abnormal lymph nodes calcifications looks like breast cancer. Male breast CA. Some trivia on calcifications: microcalcifications alone are uncommon in men. When you see them they are less numerous, coarser, and associated with a mass. 25% of male breast cancers have calcifications. Should men get screening mammograms? Honestly, women shouldn't even get them, according to the New England Journal of Medicine. This remains controversial, with the bottom line being this: only Klinefelter patients approach the screening range with regards to risk. As a point of trivia, males with gynecomastia from gender reassignment on hormone therapy are not high enough risk for screening mammograms. Obviously, if they have a palpable finding they can get a diagnostic workup. 380. Section 12, implants. Basic overview: there are two types, saline and silicone. They both can rupture, but no one really gives a shit if saline ruptures. Saline does not form a capsule, so you can't have intracapsular rupture with saline. There is no additional imaging past mammo for saline rupture, and you just follow up with primary care at plastic surgeon. You can tell it's saline because you can see through it. For silicone you can have both intra and extracapsular rupture. You can only see extra on a mammogram, can't see intra. So extra creates a dense snowstorm appearance on US. Intra creates a stepladder appearance on US and a linguini sign on MRI. MRI is done with FST2 to look at implants. Big points: you can have isolated intracapsular rupture. You cannot have isolated extra, it's always with intra. If you see silicone in a lymph node you need to recommend MRI to evaluate for intracapsular rupture. Implant location: there are two subtypes, subglandular, retromammary implant behind breast tissue, anterior to pectoral muscle, subpectoral, retropectoral implant between pectoralis major and minor muscles. Silicone implants. The body will form a shell around the foreign body, implant, which allows for both intracapsular and extracapsular rupture, an important distinction from saline. About 25% of the time, you will see calcifications around the fibrous capsule. Things to know: implants are not a contraindication for a core needle biopsy. Implants do not increase the risk for cancer. Saline implants. There are also subglandular and subpectoral subtypes. You can tell the implant is saline because you can see through it. Implant folds and valves can also be seen. If it ruptures no one really cares, other than the cosmetic look. The saline is absorbed by the body, and you have a collapsed implant. A practical point of caution: be careful when performing a biopsy in these patients. Even a 25G FNA needle can burst a saline implant. Trivia: some sources say that physical exam is the test of choice for diagnosing saline implant rupture. This is variable depending on what you read, who you ask. 381. Implant complications. Generally speaking, MRL is the most accurate modality for evaluating an implant. Capsular contracture: this is the most common complication of implants. It occurs secondary to contraction of the fibrous capsule, and can result in a terrible cosmetic deformity. You see it in both silicone and saline implants, but is most common in subglandular silicone implants. On mammo it looks like rounding or distortion of the implant. Comparisons will show progression. Gel bleed: silicone molecules can, and do, pass through the semi-permeable implant shell coating the exterior of the surface. This does not mean the implant is ruptured. The classic look is to show you silicone in the axillary lymph nodes. Remember, I showed a case of this under the lymph node section. Even with axillary lymph nodes, this does not mean it has ruptured. Rupture: as a point of testable trivia, the number one risk factor for rupture is age of the implant. Rupture does not have to be post-traumatic, it can occur spontaneously. Rupture with compression mammography is actually rare. Saline rupture is usually very obvious, deflated boob. It doesn't matter all that much except cosmetically, as the saline is just absorbed. On mammo, you will see the wadded up plastic wrapper. They could easily write a question asking you what modality you need to see a saline rupture. The answer would be plain mammo. You don't need ultrasound or MRI. Silicone: this is a more complicated matter. You have two subtypes, isolated intracapsular and intracapsular with extracapsular. Oh, isolated intracapsular: this will be occult on physical exam, mammography, and possibly ultrasound. You might see a stepladder on ultrasound. MRI is way more sensitive. Oh, intracapsular with extracapsular rupture: this is usually obvious on mammogram with dense silicone seen outside the capsule. The contour of a normal intact implant is smooth. Silicone outside the implant can go to lymph nodes. On ultrasound you want to know the buzzword snowstorm pattern, which is really echogenic with no posterior shadowing. A sneaky trick is to show a lymph node with a snowstorm appearance on ultrasound. On MRI, extracapsular silicon is TL dark and T2 bright. Lastly, a very important concept is that you cannot /Jave isolated extracapsular rupture. If it's extracapsular, then it's also intracapsular. 382. L. Radial folds, the mimic of rupture. Radial folds are the normal infoldings of the elastomer shell. They are the primary mimic. For the linguini sign of intracapsular rupture. To tell them apart, ask yourself, do the folds connect with the periphery of the implant? Radial folds should always do this, linguini does not. 0. Silicone implant rupture summary. Ultracapsular rupture, remember the capsule, is not part of the implant. It's the fibrous coat your body makes around the implant, the outer black line in my diagram. Silicone can rupture through the shell of the implant, but stays confined inside the fibrous coat. This is intracapsular rupture. The classic sign is the floating linguine, as in this case. Extra and ultracapsular, this is when the rupture goes through the capsule, the thing your body made. You cannot have isolated extracapsular silicone. It has to make it through the implant shell first. Silicone outside the capsule can create a snowstorm look on ultrasound. It can also infiltrate lymph nodes and do the same, snowstorm nodes. Remember, gel bleed can also give you a node like this. Radial folds, guys like squishy boobs. The bigger and the squishier the better. Therefore, implants are not bound tightly, so they can be squishy. Because they are loosely bound, the shell infolds creating radial folds. The folds always attached to the shoe. The folds are thicker than a rupture, because they represent both layers. 383. Section 13. Post-op post therapy. Reduction mammoplasty and mastopexy. Reduction mammoplasty, yes, there is actually a subpopulation of women who want smaller breasts. I know it sounds impossible to believe from a man's perspective. Mammoplasty is done to reduce breast size. Mastopexy, this is a breast lift. This is just a removal of skin. Women get this done to address floppy, ptotic boobs. Normal findings post-mastopexy, swirled appearance affecting inferior breast. Typical changes from mammoplasty. Fat necrosis, oil cysts, isolated islands of breast tissue. Keyhole incision, this is done for both mammoplasty and mastopexy, creating a swirled appearance in the inferior aspect of the MLO. Mammoplasty keyhole incision, mastopexy keyhole incision. 384. L. Surgical biopsy, irradiation. Terminology, lumpectomy, surgical removal of cancer, palpable or not, excisional biopsy, surgical removal of entire lesions, incisional biopsy, surgical biopsy of a portion of the lesion. Post-biopsy changes. The first post-operative mammogram is usually obtained around 6 to 12 months after biopsy. The key is that distortion and scarring are worst on this film, and should progressively improve. On ultrasound, scars are supposed to be thin and linear. If they show you a focal mass like thickening in the scar, you've got a call that's suspicious for local recurrence. Fat necrosis and benign dystrophic calcifications may evolve over the first year or two, and are the major mimics of recurrence. Fat necrosis can be shown on MR, TL/T2 bright, and then fat sat drops it out. Risk of recurrence, residual disease. Numerical trivia, local recurrence occurs 6 to 8% of the time, when women have breast-conserving therapy. The peak time for recurrence is 4 years, most occur between 1 to 7. Without radiation, local recurrence is closer to 35%. Tumors that recur early, 3 years, typically occur in the original tumor bed. Those that occur later are more likely to be in a different location from the original primary. What gets recurrent disease? Risk of recurrence is highest in the oomenopausal woman. Think about them having an underlying genetic issue. Other risks are having an extensive inarticular component, a tumor with vascular invasion, multicentric tumors, positive surgical margins, or a tumor that was not adequately treated the first go-around. Residual calcifications are not good. Supposedly residual calcifications near or in the lumpectomy bed correlates with a local recurrence rate of 60%. New cales, when it does reoccur, something like 75% of DCIS will come back as calcifications, no surprise. The testable pearl is the benign calcifications tend to occur early, around 2 years, vs the cancer ones which come back around 4 years. Sentinel node failure. Sentinel node biopsy works about 95% of the time, doesn't work 5% of the time. So about 5 times in 100 you are going to have a negative node biopsy that presents later with an abnormal armpit node. Tissue flap. The cancer is not going to start in the belly fat eye muscle. The cancer is going to come from either the residual breast tissue or along the skin scar line. Screening of the flaps is controversial, with some saying it's not necessary. The need for screening of tissue flaps is not going to be asked. If you get asked anything, it's where the recurrent is coming from. I going to be specimen radiography. If the path report says close margins or positive margins, there's a very high chance you are going to have cancer still in the breast. If you are shown a specimen radiograph, there are 2 things you need to look at in real life and on multiple choice. 1 is the mass calcifications on the sample, and 2 is the mass calcifications near the edge or touching the edge. If the mass is at the edge, the chance of incomplete excision is going to be near 80%. The next step would be to call the surgeon in the OR and tell him/her that. Post-radiation changes. Specimen radiograph, cancer at the margin, high chance of positive margin. Practical point, the before picture, the pre-radiation mammogram is very important. If you can identify residual disease on it, the patient has many more treatment options. If you discover the residual disease after the radiation therapy has been given, you force the patient to undergo mastectomy. Radiation changes, you are going to see skin thickening and trabecular thickening. This is normal post-radiation and should peak on the first post-RT mammogram. This would be a classic testable scenario. Film 1 post-root, you see skin thickening, trabecular thickening. Film 2, skin thickening, trabecular thickening is better. Film 3, skin thickening, trabecular thickening is worse. Asterisk, this is recurrent disease, maybe inflammatory breast CA. Secondary angiosarcoma. The primary type is so rare I didn't even mention it. The secondary types are seen after breast conservation therapy, irradiation therapy. It takes around 6 years post-radiation therapy to develop one of these things. Clinically, the classic presentation is a red plagues or skin nodules. The challenge with these is that the skin thickening due to the cancer is often confused with post-therapy skin thickening. 386. L_. Staging/surgical planning. Breast cancer staging. The staging is based on size from TL, T3, then invasion for T4. TL equals 2 centimeters. T2 equals 2 to 5 centimeters. TJ equals 5 centimeters. T4 equals any size, with chest wall fixation, skin involvement, or inflammatory breast CA. Asterisk, remember that Pagels is not T4. Trivia, axillary status is the most important predictor of overall survival in breast cancer. Trivia, melanoma is the most common tumor to met to the breast. The contraindications for breast conservation are high yield. Contraindications for breast conservation. Inflammatory cancer. Large cancer size relative to BREA T, multicentric, multiple quadrants, prior radiation therapy, to the same breast contraindication low radiation therapy, collagen vascular disease. 387. SEC110N14, breast MRI. Breast MRI can be used for several reasons: high-risk screening, extent of disease, known cancer, axillary mets with unknown primary, diagnostic dilemmas, and possible silicone implant rupture. The big reason is for screening. I'll just briefly go over how it's done and how it's read. You need a special breast coil and table setup to make it work. The patient lies belly down with her breasts hanging through holes in the table. You have to position them correctly, otherwise they get artifact from their breasts rubbing on the coil. Basic sequences are going to include a T2 and pre and post-dynamic post-contrast fat-saturated TL. Remember, the breast is a bag of fat, so fat sat is very important. Dynamic imaging is done to generate washout curves, similar to prostate MRI. My basic algorithm for reading them is to 1. Look at the background uptake. I use this to set my sensitivity when I compare it to prior studies. Ideally, you use the same kind of contrast and imaged at the same time of the month. As I'll mention below, hormone changes with female cycles cause changes in how much contrast gets taken up, less early and more later. 2. I look for masses or little dots, foci. MIPS, maximum intensity projections, are helpful just like looking for a lung nodule. LFL, see a mass or dot. I try and characterize it first by seeing if I can make it T2 bright. Most T2 bright things are benign: lymph nodes, cysts, fibroadenoma. If it's not T2 bright, I look at the features: is it a mass? Is it spiculated, etc. These features are more important than anything else. Is it new? Nipple enhancement is okay, don't be a dumbass and call it Paget's. 3. Finally, I'll look at the washout curve, but honestly I've made up my mind before I even look at that. I will never let a benign curve back me off suspicious morphology. 4. I deal with the findings similar to mammo. New masses get BR4 or BR5. NMLE, non-mass-like enhancement, gets BR4D if new. T2 bright stuff for the most part, there is one exception of mucinous cancer, gets BR2D. Anything with a 4 or a 5 gets biopsy, via MR-guided stereo. I never pussyfoot out and BR0 something on MRI, unless it's a technical problem, example inadequate fat sat. 388. L. Who gets a screening MRI? People with a lifetime risk greater than 20 to 25% includes people who got 20 GY of radiation to the chest as a child. How do you estimate this risk? To decide who is 20 to 25%. You use one of the risk models that includes family history, not the Gale model. If the question is which of the following is not one to use, the answer is Gale. If the question is which of the following do you pick, I chose Tyrakuzic, it's probably the best one out now. Parenchyma enhancement. Is it normal? Yes. Where is it most common? Posterior breast in the upper outer quadrant, during the lateral part of the menstrual cycle, luteal phase, day 14 to 28. How do you reduce it? Do the MRI during the first part of the menstrual cycle, day 7 to 14. What does tamoxifen do? Tamoxifen will decrease background parenchyma uptake. Then it causes a rebound. Foci. How is it defined? Round or oval, circumscribed, and less than SMM. Are they high risk? Usually not. Usually they are benign. 2 to 3% have a chance of being a bad boy. What would make you biopsy one? Seem different than the rest, ill-defined borders, or suspicious enhancement. Can you be LRADS 3-1? If you have a solitary focus, 5 MRN, with persistent kinetics on a baseline exam, you can BI-RADS 3 it. NMLE, non-mass-like enhancement. What is NMLE? It's not a mass, but more like a cloud or clump of tissue enhancement. What are the distributions? Segmental, triangular blob pointing at the nipple, indicates a single branch, regional, a bigger triangle, and diffuse, sorta all over the place. Which one is more suspicious, homogeneous or heterogeneous enhancement of NMLE? Heterogeneous is much more suspicious. 389. Masses. T-HAs are defined as being 5 RNM or larger. They have definable vocabulary for their features: round, oval, indistinct, etc. When are these bad? They are bad when you call them bad words. Irregular shape, speculated margins, heterogeneous or rim enhancement. Once you say those words, you are going to have to biopsy them because morphology trumps kinetics. It doesn't matter what the kinetics shows, you must biopsy suspicious morphology. When is kinetics helpful? When you are on the fence. If you have benign morphology and you have suspicious kinetics, you probably are going to need to biopsy that also. Kinetics. Breast kinetics are performed in 2 portions. 1. Initial upslope phase that occurs over the first 2 minutes. This is graded as slow, medium, or rapid if fast. 2. The washout portion, which is recorded sometime between 2 minutes and 6 minutes, around about. These are graded as either continued rise type 1, plateau type 2, or rapid washout type 3. Risk of cancer, ... Persistent. O type 1 curve, 6%, O type 2 curve, 7%, 28%, O type 3, 29% or more. Colon, ___________________________________________________________________________________________________________________ L underscore dash classic low